who are able to watch to give their presentation, and then you'll have the opportunity to ask some questions at the end. Unfortunately, we won't be able to take any questions from people who are online, so it's really just questions from the audience here today, and you'll just have to speak up because we don't have a microphone to give you, but it's quite a small room, so that shouldn't be a problem. For those of you that don't know me, I'm Caroline McElnay, and I'm Director of Public Health here at the Ministry of Health. And it gives me great pleasure to introduce our two speakers for today. We have Professor Ed Gane from the New Zealand Liver Transplant Unit and Dr. Homi Razavi, who is based in the US from the Centre for Disease Analysis. And they're going to talk to us today on viral hepatitis in the New Zealand context. Dr. Razavi is going to present some of the modelling work that he's undertaken on hepatitis C, both for New Zealand and overseas. I hope that's right. And Professor Gane will present on what we need to do here in New Zealand to achieve viral elimination. So just before they start, and I'm going to leave it to the two of them to do it in whichever order they want to do it, or do it together. We won't take questions while they talk. We'll save up your questions for the end. So if I'd just like to introduce Homi first of all. Homi's the founder and managing director at the Centre for Disease Analysis, based in Colorado. So the CDA specialises in studying complex and poorly understood diseases in order to provide countries with data and information to support effective decision making. Since 2008, Dr. Razavi has led a team of epidemiologists and modellers to quantify the epidemiology of hepatitis C virus and forecast the future impact of the disease burden. They've analysed HCV disease burden in over 100 countries, working with government health officials to develop national strategies for managing HCV that best utilises the available funds. CDA has also recently launched the Polaris Observatory in order to share the findings more broadly, and that's an online database of epidemiology and disease burden data for hepatitis B, C, and D. Professor Ed Gane, who many of you will know, is Chief Hepatologist and Deputy Director at the New Zealand Liver Transplant Unit and Professor of Medicine at the University of Auckland. He's also Chair of the Ministry's Hepatitis C Implementation Advisory Group and a board member for the Hepatitis Foundation of New Zealand. Professor Gane has published widely. He's led many international clinical trials of therapies for chronic viral hepatitis. We're also very pleased to have with us, hopefully they're still here, yes, Susan Hay, who's the CEO of the Hepatitis Foundation of New Zealand, and Professor Chris Cunningham. Thank you. And we're also joined by Pharmac representative, Matthew Tyson. So enough from me. Welcome everyone. I will hand over to Homi and Ed. Thank you.
Thank you very much for that very kind introduction and the invitation to be here. It's an absolute pleasure to be back in New Zealand and more importantly in Wellington. What I'll do today is tell you about some of the modeling work we'll be doing to assess what it would take to actually achieve hepatitis C elimination in New Zealand. And then also, we at the last meeting, there was a request that why don't we take a look and see what the economic impact of these strategies would be and how much it would cost. Here are my conflict of interest statements. This program was actually funded by a grant by John C. Martin Foundation and by Center for Disease Analysis. Now, the work that I'll describe would not have been possible if it wasn't for the inputs of the following experts. So Professor Gane, Dr. Steadman, Cheryl Britton, Sarah Atke, Charles Henderson, and the Hepatitis Foundation. In fact, this was a collaborative effort for the last 2.5, 3 years actually that we've been working to assess the disease burden in New Zealand and then look at the impact of different strategies and more recently the cost. What I'll do is I'll go through 4 topics. What are the hepatitis elimination goals? So New Zealand has signed into the WHO declaration. And then give you an overview of what's happening around the world, and then really dive into New Zealand. What's the disease burden, hepatitis C disease burden? under different scenarios, and then what would be the cost associated with each one of those strategies. So this is the outline of the hepatitis elimination targets. What you have is you've got two categories. You've got prevention, treatment, and you have targets for 2020 and targets for 2030. I have gone through and actually put check marks next to the portions of the goals that have already been met by New Zealand. So in terms of 3-dose hepatitis B vaccination, we're already over 90%. In terms of birth dose, we're already over 90% among those who are surface antigen positive. The blood supply is, so donated blood is screened 100%. And of course, there's no reuse of glass syringes or unsafe injections. So we've met those. In terms of harm reduction program, we're somewhere between 200 and 300 sterile syringes distributed, a needle syringe per PWIP. So we've already met the 2020 targets. Now, what's left is what's on the bottom. So what we need to do to meet the 2030 targets is to diagnose 90% of the hepatitis C population. We're currently about 50%. For hepatitis B, we're about 60%. So we've already met the 2020 targets for both Hep B and Hep C. And the other is to treat about 80% of the eligible population. I'll go through that and show you what we've done so far, where we're at today. And then 90% reduction in new infections. So for Hep B, we've already met that through vaccination. For Hep C, unfortunately, as you know, there's no vaccines available. So really, the mode of reduction in incidence really has to be treatment as prevention. So treating high-risk population, bring the viral load down, and that will reduce actually transmission. And then the 65% reduction in mortality is very closely linked to treatment. So in fact, as you increase treatment, you can reduce the mortality as well. So that's what's left. Everything in the red is what we need to do as part of a national program if we want to meet these targets by 2030. Now, what's important is that WHO goes through and that they provided guidelines for developing national viral hepatitis plan. And what I've highlighted in red is key. Is not only there needs to be a national plan for hepatitis, but an allocated budget, and that's quite quickly that's coming in together. But one of the shortcomings that we've seen in a number of countries is they put together a very detailed plan without allocation of resources. So what's happening globally? If we look at globally in terms of hepatitis C, the wide distribution, the colors represent the percent of the population that's infected. So we have the red is somewhere between 3 to 7%. And the size of the bubbles or the circles correspond to the population that's actually infected. So you have a country like India that has a very low prevalence, so percent of the population is low, but there's a lot of people in India. So in fact, a large number of people are infected with hepatitis C in India. Compare that to Mongolia, where the prevalence is quite high, but in fact it has a low population, so the bubble size is quite small. Both Australia and New Zealand actually fall between 0.8 to 1.3% actually. And what's important to note is that actually the majority of the hepatitis C infections globally, so about over 80%, are in low and middle income countries globally. The cascade of care, about 80% of the population globally remains undiagnosed. So compare that against New Zealand, which is around 50%. So we're doing quite well here. And 97% of the population globally remains untreated, actually. So remember, the treatments are available, and they are curative, and yet only 3% of the population is actually being treated globally. Now, there's a bit of a good news, bad news. The good news is that if you look at globally, this is the total number of treated globally, and we're about 2.1 million actually. So the number of treated individuals has been increasing. That's fantastic. The bad news is that the majority of this growth is actually happening in middle-income countries. So the red line represents lower middle-income countries. The blue line represents upper middle-income. Not surprisingly, the number of treatment in low-income countries is quite low. But take a look and see what's happening in high-income. In fact, what we saw globally is an increase and then a decrease. And the reason this is really important is, wanted to really highlight this. This is what we're going to expect happen in New Zealand without further interventions and without further programs. And this is not, this is consistent. So if you look at the US, we saw a decrease as there was warehousing holding back patients with the new treatment. New treatments became available. We saw a sharp increase, exactly the same thing, 2013, the warehousing increase, and we've seen a dramatic decrease in between 2016 and 2017. Same thing in Australia, and in fact this continues to go down. Same thing in Spain, same thing in Germany. And the key thing here was that initially everybody thought as treatments would become available, that people could walk up and seek treatment. In fact, you see a little bit of that, but in fact, who's coming to seek treatment are those patients who are already under care, right? So you have a large portion of the population who's diagnosed, who are not under care, and those are the ones that are actually are left behind. That's assuming they're diagnosed, though. The undiagnosed population, it doesn't even know that they have Hep C. And probably the most dramatic example of that is Australia, where 80% of the population is estimated to be already diagnosed, and yet we already see a decrease in number of treated patients. And the treatment in Germany, in Spain, Australia, and Japan is available free of charge to all citizens. US, we have our problems. So currently we estimate that there are 12 countries that are on path to elimination. And so if you look at the greens, of course, Australia is on there, Egypt, Mongolia, France, Georgia. So these are all the countries that are on path to elimination. The yellows, they're working toward it, and the red, they're unlikely to achieve it using the current programs. And what's interesting is we started looking to see what are the patterns in these countries, and we found that there were 7 requirements to achieving WHO targets, actually. They have to have a national program that's financed, and that's one. They have to have harm reduction programs in place. Because remember, you can't eliminate unless you reduce number of new infections. In most countries, you have to expand capacity beyond specialists. There are a few countries that already have enough hepatologists and gastroenterologists. Iceland is a good example. You only have 2,000 infections in the whole island. So you really don't need to expand that. The current medical system can actually handle that. Removing treatment restriction, implementing monitoring and evaluation systems, implement awareness and national screening campaigns is really big, and linkage to care program. So if you have all of these, you should be able to achieve it. And what we did was we started going through the list of countries to see if there are countries that meet all of these targets, and in fact there are. There are countries that can put check mark against all that, and yet they're still not on the list. And the reason is systems are very good at meeting targets on surface, but not in spirit. And in fact, the most common denominator among all the countries that were already on path to elimination was political will. So you'll have countries that say, look, there are absolutely no restrictions, except they won't provide a budget, right? And so when you talk to the physicians, they say, look, I've already treated my caseloads, and we can't treat anymore for the year. So in fact, there are restrictions in place. So political will, it seems to be a key driver. And in order to measure how countries are succeeding is the treatment rate. So if they're treating more than 7% of the population in a given year, they're likely to meet the WHO target. Simple math, we have about 12 years left. 1 over, actually we started this last year, 1 over 13 is right around 7%. So they have to treat over 7% of their population. If you look at the countries that were on that list and you see how they're doing against these measures, one becomes fairly common. All of them have political will. The government has not only agreed, but they're actually taking steps to eliminate hepatitis. They're all financing the national program, and they've all removed restrictions. Now, monitoring and evaluation, most of them have that in place. If not, they're actually putting it in place. National screening program, again, Australia, Egypt, France. A lot of these are national programs to the general population, high-risk population. Mongolia screened everyone between the ages of 40 and 60 last year. And this year, they'll screen everyone over 18. So these are large national. Egypt is going village by village and actually doing general population screening. Spain has just started doing large screening, especially in the Catalonia region. So again, not every country has to meet all targets, but they're all working toward national screening program, registries, and expanding treatment to GPs, with a few exceptions, and those are to be smaller countries. Iceland is a good example where they don't need GPs, and Georgia may actually be able to get away without it as well. All right, so let's take a look at New Zealand. And Professor Gane is going to go into much more details in terms of what the burden looks like in New Zealand. So I'm just going to give you a very high level. We estimate that there are about 50,000 people infected, RNA positive. Big distinction between antibody. So antibody will show that if they've ever been exposed to hepatitis C virus. RNA positive means that they actually have an active infection. So we estimate about 50,000 are RNA positive. Now, anytime anybody tells you an estimate, you should ask them what year. Because prevalence, total number of infections, is never flat. It's either going up or it's going down, right? So in 2013, we estimated there were 50,000. By 2017, we estimated there's about 45,000. So think of it in terms of a series of pools. You have new infections coming in, you have people being cured, and you have mortality. Now, they could die of natural causes or could die of liver-related death. But in fact, number of new infection in New Zealand is expected to be fairly low. You don't have a huge injection drug use problem like Eastern Europe or the US. So in fact, we expect that total number of infections would decrease. We've diagnosed about half of that population. Each year, we're diagnosing about 900. And as of 2017, we had restrictions. So genotype 1, anyone could be treated. For genotype 2 through 6, only individuals with decompensated cirrhosis. Very familiar graph in New Zealand, so fairly flat. You saw warehousing and a sharp increase. Without further intervention, what you saw in Germany and Australia and the US is we would expect this to come down. So if the restrictions are removed, what we typically see is a bump of about increase about 25% in treated patients, and then a decline. So if restrictions are removed in New Zealand, we will see a slight increase, but then the year after, without intervention, without further programs, it will actually most likely decrease. So this is what the cascade of care looks like. 45,000 people infected, half of those are treated. We are restricting treatment in G2 through genotype 2 through genotype 6. So there's about 13,000 of the diagnosed population who can be treated, not all under care, and that's the big distinction. And about 3,000 of those are actually being treated. So when we look at the disease burden, the question is, what are the scenarios that we want to look at? An easy one is, well, look, let's take a look at inaction. What if we just stop? 2017, we treated 3,000, we've diagnosed. Here's the treatment restrictions. F0, anyone can be treated, so no restriction. Sorry, G1, no restriction. G2 through 6, only decompensated cirrhosis. We estimate about 1,000 new infections annually. Anyone between 50 to 74 can be treated. SVR is quite high. So the inaction scenario says, let's just stop the program and just see what will happen. It's modeling, so it's fairly easy to actually implement that and show that. The second one is to look at, what happens if we just continue doing what we're doing today. So we treated 3,000 in 2017. What the modeling predicts is that, in fact, the number of treated patients will decrease over time if we continue with the same programs in place. So restrictions for G2 through G6, and we continue to diagnose the same number. So just the base scenario is what's happening today, continuing to the future. And then from a modeling perspective, we can actually back calculate. So we went in there and we said, look, what does New Zealand have to do in order to meet the WHO targets, the 2030 targets, right? So, 90% diagnosed, 80% of the eligible population treated, 65% reduction of mortality. And we're actually not that far off. So this was really surprising. So we treated about 3,000 last year. In fact, if we keep it right about 3,000 to 4,000, and actually after 2025, we're going to start running out of patients, so we don't have to keep it up. We can meet it. But in order to do that, what's required is screening. So what you're seeing is how many people we need to newly diagnose per year. But in fact, the number of people we need to screen is going to be substantially higher. If your prevalence is 1%, you need to screen at least 100 more, 100 people to find one. So just 200,000. And I'll show you that I got some math tomorrow that actually shows how many people actually need to be screened. Now, in order to meet the WHO targets, remember, we're going to have to remove restrictions, so this requires pan-genotypic treatment. And if we do that, then we will also see a reduction in incidence. So we do fully expect that the number of new infections will actually decrease. So let's take a look and see what the effect is. The total number of viremic infections, if we simply stop all the programs today, will be somewhat flat, slight increase, but we will see a massive increase in the number of new liver-related deaths. So almost a 2x. We'll see increase in hepatitis C carcinoma and decompensated cirrhosis. Now, what if we continue doing what we're doing today? The good news is that the prevalence, the total number of hep C infections will actually decrease over time. So we're treating, we're curing, but in addition, we're also reducing the number of liver-related deaths, hepatitis C carcinoma, and decompensated cirrhosis as well. So total infections will actually reduce by almost 25%, but more importantly, we'll save 1,200 deaths over this time period, and we'll reduce number of HCC cases by almost 700. All right, so let's take a look at what happens if we go after WHO elimination targets. So again, we're not talking a massive increase in treatment. In fact, all we need to do is just keep it at about 3,000 to 4,000, but expanded screening and diagnosis. If we do that, total infections will actually increase by over 80%. So massive decrease in the number of infections. We'll also see a substantial decrease in the number of liver-related deaths. So we'll save 2,300 deaths in New Zealand. And HCC will drop by 1,600. So this will have a very, very large impact in terms of both mortality and morbidity. But there's going to be costs associated with that, right? So let's take a look and see what the economic impact is. So we spent some time actually gathering data. Professor Gane was kind enough to provide what are some estimated costs for healthcare costs. So if someone's F0 to F4, we estimated that it costs about $250. So this is compensated cirrhosis. Sorry, this is F0 to F3. It should say F3. If they're diagnosed, $250. So this is for testing, coming to see a physician. If they're not diagnosed, the cost is zero, right? So the big thing here is that you only incur these costs if the individuals are diagnosed, right? Compensated cirrhosis, about 2,800. Decompensated, about 23,000. Hepatitis C carcinoma, this is annual cost, 30,000. Liver transplant, 200,000, and subsequent year, about 4,600. So those are healthcare costs. Now, we also need to look at the diagnostic costs, because if we implement the elimination program, we need to screen more people. So we estimate that today it costs about $12 to run an anti-HCV test. Now, in the elimination program, you wouldn't continue to incur these costs. You can actually negotiate lower costs, similar to what Pharmac did for medicine. And in fact, that could come down as low as $2. For RNA, 230, it could come down as low as 50. Genotyping is not going to change much, but if it's pangenotypic, it's likely you could eliminate that. And staging fibrosis is going to stay the same. So in order to find someone, whether they're Hep C positive, we're going to need to do an anti-HCV test. Currently, we run 2 PCR, 1 genotype, 1 fibroscan, or staging and per patient. But in the future, with pangenotypic, we can eliminate that as well, so that can go to 0. Now, what about the treatment cost? We ran 2 scenarios. Under the conservative scenario, we said, well, what if the treatment cost 20,000 New Zealand dollars per patient to cure for F0 to F3? This is F in genotype 1. If they're cirrhotic, it's twice the duration, so 40,000. And then for genotype 2 through 6, remember F0 to F3 are not eligible for treatment, so about 70,000 New Zealand dollars. But if they were, it would cost, the duration of treatment would be. Now, again, these costs are negotiated, so it could go as low as, for pangenotypic treatment, 10,000 for F0 to F3, and then for 8 weeks, and for 12 weeks, it would cost 15,000 for both genotypes, for all genotypes, essentially. Look to see what it would cost to actually implement the national registry. We estimated that it would cost about 100,000 annually to have just a registry in place and keep that up to date. Now, those are direct costs. So those are out of pocket, what the public health system will actually spend. There's also the indirect cost of societal costs. So disability adjusted life here says, look, if I've got a healthy life, my life expectancy is here, but with a disease, we'll have disability. So there's a number of years to live with disability, so that reduces the productivity of the individual. But you also have shorter life expectancy. So you have to include in there years of life lost. So in fact, the orange period is what you lose as the result of the disease. Now, you have to assign a cost to that. We just put in 1 GNI per capita in New Zealand, which is around $57,000. So for every year lost, we're losing $57,000. So let's take a look and see what the effect is. So what you're looking at is a graph that shows what the cost of treatment and laboratory. So not screening, just the laboratory. So we run the RNA test and fibroscan. And what you're looking at, this axis is the time over period, and this is the total cost of the public health system. So if we just stop all programs, the red line, there's no cost. So good news is 0 cost. The current program, remember we said that treatment is going to decrease, and we've seen this in other countries. And so right now, in 2018, we estimate that we're spending about 70 million New Zealand dollars actually on treatment and lab costs, but that will actually come down over time. Now, for the WHO targets, we're around 2 scenarios, one at the high cost and one at the low cost. So the curves are quite similar. What you see is an increase in treatment and lab cost. It will come down. By 2025, you start running out of patients, so it comes down. And by 2035, you essentially treat all you can treat. And so, in fact, that cost comes down close to 0. And you see that. So the difference between these 2 curves is simply the pricing. Now, in order to achieve these, you're going to have to screen a lot more people. And so, in fact, if you look at the base 2017, this is what we're currently spending, and that's what we will continue to spend going forward. In action cost 0. But for screening costs, if we continue to screen in order to find population, meet the WHO target, that's going to have to ramp up. By 2026, again, we start running out of people to screen. There's some low level, right? So we're not going to go to 0. Again, the 2 strategies at different price points. Those are the costs that we're going to incur. But when you treat people and you cure, you're going to incur lower healthcare costs. So in fact, the price of inaction is you're going to have a lot more HCC, decompensated cirrhosis, liver transplants. So the cost, the healthcare cost, is expected to rise. the healthcare costs under the base scenario is actually starting to decrease. But if you go take the elimination strategy, the healthcare cost is going to substantially decrease. So really, to look at the direct cost, you add up all those three graphs together, and this is what you get, essentially. So this is all direct costs, hospital costs, screening costs, treatment costs, all combined. And what you see is the fact that if the prices of the medicines and diagnostics are high, you're going to spend a lot more than what you're spending today. But if you can negotiate lower prices after 2025, you'll spend actually less. Okay. But if I'm the Minister of Health, I don't really care about annual. Well, I do care about annual costs, but more importantly, I want to know how much I'm going to spend total, cumulatively, right, from today forward. Sorry, I jumped the gun a little. So those are the direct costs. But there's the indirect costs, right? So if we don't treat, what we're going to have is shorter life expectancy. We're going to have higher death. So inaction, disability adjusted life year will increase. Under the base, it increases slightly, and under WHO targets, it will decrease. And so one of the measures is cost per DALY averted. And what's interesting is that the WHO target, the optimistic, is actually cost saving. It's actually below zero, right? But even at higher prices, if we can't negotiate it, the very conservative scenario, by 2023, we're below 3 GDP per capita, so that's considered cost saving. By 2027, we're below 1 GDP per capita. So by 2027, we are highly cost effective, actually. Good news is treatment actually and the screening is highly cost effective, even the worst case scenario where we can't negotiate prices and we have the higher prices in there. Now, if we look at all the direct costs cumulatively, of course, the WHO is conservative. So between now and 2030, what we estimate is that under the conservative scenario, we will spend about 1.2 billion total going forward. But if the prices are lower, then it'll be right around 600 million cumulatively. Compare that to the base scenario, of course, that's going to be higher. So in fact, the WHO targets, if we can achieve the optimistic prices, will actually cost less. And if you look at the return on investment, it will have a positive return on investment. The conservative scenario, if you look at purely direct costs, it will have a negative ROI. But remember, what we're ignoring here is the people dying, right? So we're basically saying that the least costly strategy is not to do anything, because we don't have to spend anything. But we're actually not looking at the quality of life and the life saved. If you put those in there, then you get a different picture. So now this is direct and societal costing combined together. And in fact, even the conservative WHO scenario ends up cumulative costs actually cost less after 2027. The optimistic scenario always costs less, actually. Moral of the story, this is a lot of graphs, a lot of numbers, is that achieving WHO targets, even using conservative prices, is highly cost effective. If we can get the optimistic prices, it's cost saving. In fact, New Zealand will spend less than it currently is. And by including the societal cost, in fact, both of the scenarios are highly cost effective, and they both have positive ROIs. In conclusion, I just want to wrap up and say that there are 12 countries on path to elimination. We would love to see New Zealand on this list next year. And the common theme among them is political will, a financed national program, no restrictions in place. Now, New Zealand will need a really robust screening program to meet WHO targets. The treatment, you've already shown that the system, the healthcare system, has enough capacity to treat 3,000 people. Engaging more primary care physicians into the system will actually allow us to even treat more. But remember, we really need to treat between 3,000 and 4,000. The WHO target scenario are cost effective. There's no question about that. The optimistic scenario is actually cost saving from day one. Now, the incremental drug laboratory and diagnostic costs are offset by the cost of healthcare costs, and that's what we often forget. We focus on the cost of treatment, the cost of screening, but remember, by actually screening, finding those people and treating, we will spend less on liver transplants, HCC, hospitalization, and their quality of life will improve and expect longer life expectancy. Under the current treatment paradigm, the New Zealand public health system is expected to spend about 720 million New Zealand dollars between now and 2030 just on hepatitis C. The optimistic scenario will actually cost less, so it's considerably cost saving. And when we look at societal costs of deaths and disability, look, all of these are cost saving. I'm going to stop there and turn it over to Professor Gane, and then we'll open it up for questions. Thank you very much.
Yes,
That's it.
so you've seen this, I think. This is just, I think that's the first, yeah. This is the global targets, as you recall, reducing new infections, getting people onto treatment who are eligible for treatment for Hep C. That will be 100% of people with virus will be eligible for treatment now. And to reduce deaths from hepatitis C, liver cancer and liver failure by 2/3. So can we eradicate Hep C in New Zealand? You've heard Homer's modelling, but in reality, can we do that? I think it's important to come back to the crucial assumptions Homer uses as model, and that is, first of all, how many people are infected in New Zealand? We know that Australia has very high diagnosis rates. We think 80, they say 85% of people with Hep C in Australia are on a national registry. And they've been managing this registry for a very long time, and they think that's a very accurate percentage. We know that here it's probably less than 50%, but we don't know the total denominator, the people with hepatitis C. And I should bring you back, the first time the ministry looked at this was the ESR report in 2000, and at Nesdale, many of you will know from Public Health, was the first author. Cheryl, Catherine and I were also on this. And this used all the prevalence data we had available in 2000. And these were small numbers of people, very limited. We had healthy blood donor data, but that's not very useful because we select out anyone for hepatitis C for injecting drug use in the questionnaire, so that's always underestimated. But we did have some good data from Public Health and people who inject drugs. And we showed that around, as you can see, about 50 to 70% of people who inject drugs have hepatitis C. But we didn't have a denominator. But from the limited data we have, we said 25,000 people were living with hepatitis C. And then we went on to use different modelling, different modelling through ESR. And I won't show you the data there, but it projected that by 2010, we would have 22 cases of liver cancer and 30 cases of liver decompensation. So what happened? We actually have hard data for this, and the numbers were double that. We were actually seeing, using a model based on a denominator of 25,000 people infected, and what we knew about the natural history of hepatitis C, that we would only get half the numbers of endpoints we're actually seeing. So we went back and said, well, this must be wrong. The denominator must be bigger than this. At the same time, Australia was putting together very good seroprevalence data and modelling, and we know that their rates of hepatitis C infection, that's what Homi said, RNA positive, is about 1.1% of the total population, a bit higher, 1.4% of the adult population. And this has been used into the second modelling group, which Homi contributed to. The Ministry of Health set up a epidemiology working party in 2014. This is something he published in the New Zealand Medical Journal. And we got together more data, and we also looked at linkage to the numbers of cancers we were seeing, the numbers of liver failure. And we really moved to this figure of 50,000. So we doubled the number from the ESR report around 15 years earlier. So based on more data and based on assuming that our epidemic was similar to Australia, and it's similar in many ways. The routes of infection, the time of infection really took off. Even the genotype distribution of Hep C is the same across the two countries. So we've estimated that 50,000 people are currently infected. It's an estimate. I think it's important we go back and validate that. And you may be aware that the seroprevalence study may be getting underway later this year. And this, I think, is going to give us very important information. Arlo Upton from Community Labs has set up a study which is going through ethics to test 20,000 individual blood samples anonymously across the country, across ethnicities, across age groups, to see what is the true prevalence of hepatitis C in a very large population, in the biggest seroprevalence study we have done to date. And I think this is going to be very informative, and hopefully it will validate our current estimates of 50,000 people infected. Because we need to know what the denominator is to be able to track our hepatitis C elimination strategy. So we say there's 50,000 people infected. How many are undiagnosed? And this again is difficult. We think it's 50%. Homie's used the figure of 50%. We don't think it's as low as Australia. We think it's a lot higher as in many low-income countries, where maybe over 90%. But how can we look at how many people are infected? Well, we've got some data, and there's a big look-back program which is about to start. I won't talk about this in detail, but the community labs have looked back and found around 28,000 people over the last decades have been diagnosed with hepatitis C. And we know that many of those people have been treated either in clinical trials, in fact a large number of people have been treated in clinical trials in this country, or pharmac-funded treatment. And some of these people won't actually have active infection. But we do know there's probably around 28,000 people have been tested for hepatitis C. So maybe a bit over 50%. And we have one linkage study. And our linkage study, this is really based on advice from Greg Dorr from the Kirby Institute, was to look at the numbers of people dying from hepatitis C, and we actually had better data on people developing liver cancer from hepatitis C, to give us an idea of what was the undiagnosed population. I talked a bit earlier about liver cancer from hepatitis B. The same holds true for hepatitis C. If you develop this complication, which is at the end stage of your natural history of hepatitis C, you always are diagnosed because you die, unfortunately. You die or you get transplanted. There's really nothing in between. So we have good data on the incidence of hepatitis C related liver cancer. How many of those people who develop hepatitis C related liver cancer actually knew that they had hepatitis C? Because that would give us an idea of the undiagnosed rate. So this has been used in other countries of the world and published. So we looked at that. We've had about 600 cases of hepatitis C related liver cancer over the last 20 years. And again, that's increasing by about 10% per annum at the moment. And we found that in 40% of people who presented with liver cancer from hepatitis C, the diagnosis of hepatitis C was made after they got sick. So after they got sick from their liver cancer, and many of them, the diagnosis of liver cancer was still delayed 6 months or more. But at that stage, then they were tested for hepatitis C and found to have hepatitis C. So looking at this, I guess you'd say the very extreme end of the spectrum of hepatitis C, around 40% of people with hepatitis C remain undiagnosed. But that needs to be validated. Okay. How many people have been treated? Now we have much better data than that, because we have pharmac available data, and we have data from clinical trials, which have become extremely active between around 2015, but have now stopped. So hepatitis C clinical trials have stopped as of 2017. So we know that prior to 2016, the numbers of people starting treatment were less than 1% of the infected population per annum. Very good data. I've colour-coded, you can't see it very well, but every change in colour is expansion of treatment or advancement of treatment. Interferon plus ribavirin, pegylated interferon for all genotypes, Vaseprevir plus interferon, all interferon-based treatments. But overall, treatment uptakes went up shortly after introducing a new treatment, and then went down again. Many reasons for that. None of these interferon-based treatments are well tolerated, and many of them had very poor efficacy or cure rates. And we all know what a difference a year makes, and the announcement by Pharmac to fund Vicaripac, unrestricted for genotype 1 compensated disease, really changed the scene overnight. And Homie's already shown this data. So treatment uptake went up 2,000% in the 12 months after the 1st of July 2016. And this really was, I think, a huge shift and really made us talk about, for the first time, eliminating hepatitis C in this country. We have the highest rate of communities prescribing for hepatitis C management in the world. That may be changing with some of the smaller elimination programs we've heard about in Iceland, etc. But we have around 35% of people being treated with Vicaripac, the first all-oral treatment, were actually treated outside the hospital, mainly in general practice. So I think that's something to be applauded, and I think Pharmac's initiative with what was and is a clumsy regimen for GPs to use. I think the uptake has been tremendous. In parts of the country, such as Northland, where there's certain payments made to GPs, that's got even much higher. The majority of patients being treated in primary care. I think this is important because moving on to the next generation pan-genotypic treatment, we know that it's going to be much simpler to use for GPs. The GPs will, the uptake I think will be much, much higher. But most importantly, I don't think this has been realised, that the patient population is going to get easier to treat. The next couple of slides I'll show you are from Greg Dorr, who's done this modelling for the Department of Health and Ageing in Australia. Now this is our current treatment population, and that's 100 patients over there, so these are percentages. It's around 10% of our patients are currently cirrhotic. And around another 10% are what we call treatment experienced and had interferon. And that's important even for the new oral treatments if there are certain genotypes. So that's what we currently look at. Small experienced population, about 10% cirrhotic. That's in 2015. If you move on a couple of years, where a lot of the treatments initially really targeted cirrhotic patients. We really treated more cirrhotics than non-cirrhotics in the first few months of Vicaripac. The numbers of cirrhotics are already dramatically decreasing. The numbers of interferon experienced patients, a lot of these patients have thankfully been, because we know who they are, because they've been treated, have been recruited into clinical trials to show that the new treatments work for interferon experienced. But if you move on another couple of years, when we have pan-genotypic treatment, the cirrhotic population is going to largely disappear. And I think that's great news for a community-based treatment program. We have said up until now, cirrhotic patients should go to secondary care, non-cirrhotic patients should go to primary care. We're going to move from a 10% of the population being cirrhotic to being only a 1 or 2%, because this is happening so quickly before an ageing cohort effect. And I think they're already seeing this in Australia, where they've been going for a couple of years, that the cirrhotics have been prioritised, have been treated, and we're being left with an easier to treat population. And this needs to be emphasised to our general practitioners and our other community prescribers. Treatment uptake, this is the Pharmac data, Matt, and you're very well of this. Numbers being treated per month are starting to fall, and we've seen this worldwide. There's always a warehouse population of patients who've been waiting for identified, they're the ones who get treated, and then we need to find new patients to treat. This is even happening in Australia. So we need to work on new diagnosis. So ways to increase treatment uptake, access to pan-genotypic direct-acting antivirals, and we had the announcement from Pharmac last week that the first pan-genotypic treatment is out for consultation and may be funded as early as the 1st of October. This is a very simple treatment. I won't talk about it in depth, but it's 8 weeks for everyone in primary care. No side effects, no monitoring required on treatment, few or any drug-drug interactions. This is test and treat material. So we've done number one, thankfully, just announced. Congratulations. We need to find the undiagnosed, and Homie's talked about that. We need to increase the diagnosis rate. We need to find those lost to follow-up. And we need to improve linkage to care. You just don't need to diagnose people, you need to get them started on treatment. Now, just to remind you, Vicaripac only works in do you want me to? Okay.
You've got time to catch.
Almost half of our patients are genotype non-1, so Vicaripac doesn't work. That's why we need a pan-genotypic treatment. Undiagnosed, we're using targeted testing at the moment. We're using high prevalence populations we're targeting. These are big numbers of patients in these populations. You've got the opioid substitution therapy and community alcohol drug services. Needle exchange, and Catherine Lee, who many of you might know, is helping us coordinate a national survey to look at this population. CADS, to me, is a targeted population we must focus on. 50,000 New Zealanders attend CADS each year. 50,000 people are referred to CADS, either self-referred or referred by the courts. We expect that these people will have a much higher Hep C prevalence rate than the general population, 5 to 10%. This is a big population of undiagnosed people. Corrections I'm not going to talk about today, because I think corrections is a work in progress. But suffice to say, we do not know what the prevalence of hepatitis C is in prisons in New Zealand. We do not think it's as high as it is in Australia, where it's very high. We think here it's probably 5 to 10%, whilst in Australia it's 20 to 50%, depending on which prison. But challenges, peer testing, and this is what we're pushing for in CADS and needle exchanges, using peer workers to do the examination, do the testing, point of care testing. I'd love to push nurse prescribing, and that's work in progress. The point of care testing is a needle prick, as you mentioned, and test and treat initiatives. I think in many of these high risk populations, you should be doing testing and treating, and that's going to become easier as these diagnostics improve. For the new pan-genotypic regimen we will adopt, you don't actually have to test for RNA, you can test for something called the antigen test. Birth cohort screening, I won't deal on that. That's what's used in the US, and Hope you may want to comment. I think that has, even in the US, it hasn't been particularly successful. It won't work in New Zealand or Australia because our hepatitis C epidemic has been going on for 50 years, not 20 years. So it wasn't just a Vietnam War era or the Woodstock era. Our hepatitis C injecting epidemic has been going on for much, much longer than that. Universal testing, I want to talk a wee bit about this. This is what the French use and many other countries are now adopting. And I was speaking to somebody from CDC at the recent summit in Toronto who said they're about to start a pilot on the basis that their birth cohort screening has failed in many parts of many states of America. They're going to start a pilot of universal screening. That is, people being tested in their general practice as opportunistic screening. And as Homie said, universal testing will only be cost effective if you have a national registry. Diagnosed, loss to follow-up, we have a number of, the hospital databases have already been largely cleared out. Those were that huge hump which happened in July 2016. Carol Atmore from the college has put in an audit tool for PHOs to use to find people who have been diagnosed and haven't been treated in various practices. We have to do this because the numbers of people who are positive in each practice may be small, only a handful. And it's helpful if somebody can find these patients for the practice nurse and the GP to obtain. There will be a community look-back study. I'm not going to talk about this in depth. Arlo will talk about this tomorrow. But there is a look-back program looking at the patients who have been tested but not followed up to link them into treatment. Linkage to care, we've talked about. You don't just have to diagnose them, you have to link them with care, and you have to take treatment to the patient. So I think you can't overestimate the value of having community-based treatments in the high-risk populations. These are just ones I'm involved in. Pittman House is our community alcohol drug service. Call Centre, City Mission and Hobson Street, they do a phenomenal job treating homeless people. They've treated over 100 people with Vicaripac, which I think is phenomenal given how difficult this is to prescribe, and they have a dedicated bunch of GPs and a pharmacist and nurse. And of course, the needle exchange is shown up there on the right, and the prisons, I think, gives us an opportunity to treat large numbers of people in the community. It's safer to treat in the community. I think it's much safer, certainly for Vicaripac it is, because for Vicaripac the big problem is the comorbidities of the patients, what other medications are on. It's cheaper for the patient to be treated in the community, and we've seen that in Northland, where patients can be treated up in Kaitaia without having to come down to Whangarei. And there are some initiatives which have shown that some extra funding can help patients engage with treatment. And the most important thing about community testing and treatment is it removes the stigmatisation, which has been the biggest barrier, I think, to testing and treatment in New Zealand. So, microelimination, the Ministry has been asked to look at microelimination in New Zealand. What does that mean? Microelimination is the end. If you look at the WHO Global Health Strategy, the Western Pacific Strategy, the New Zealand Strategy, microelimination is going inside the country, looking at specific populations or people living in a specific area of the country. And WHO are very keen in pushing this. I'm not sure whether that's keeping its same vigor. This was very popular a year ago. These are the groups I think should be targeted for microelimination. We've been extremely fortunate in this country in that the top 5 are very well characterised populations of high-risk patients, but they've all been screened. We know everyone on dialysis who has hepatitis C. We know everyone post-transplant who's had hepatitis C. We know everyone with decompensated cirrhosis for hep C. All the haemophilia patients have been picked up more than a decade ago. And the HIV co-infected population, thankfully, is small in this country. We had about 100 people in my clinic with co-infection. Now we have 1. These have all been treated, largely through clinical trials. Every one of those populations have already had hepatitis C eliminated. So if you're going to look at microelimination, I think you should be looking at, as Homie said, treatment as prevention. And that's prioritising in your treatment regimens those people who are still transmitting the virus, if you want to turn off the tap, to coin this phrase. And I think we will be doing that as part of the wider access to pan-genotypic treatment. We will be targeting people in needle exchanges, people in cabs, because that's the way you halt transmission. So that's a must. Home has already said this. This is what you need to achieve hepatitis C elimination within New Zealand. This is what the countries have in common. And I think we can achieve all of these. We've already achieved one, thank you, Pharmac. I'm sure, provided we can find the patients, we'll be able to treat 7 to 10% per annum. We already have wonderful harm reduction services through our needle exchanges. These two are something we'll debate tomorrow, so all of you are coming to the summit. I think national screening programs, will they work? They must be linked to a national registry. Is that viable? And this has always been, I think, a push, and I would thank Pharmac for pushing community prescribing, even with Vicurapac. I think we're really way out in front there. While we eradicate hepatitis C, you will prevent all the liver-related complications. We haven't got time to go through, but hepatitis C causes macrovascular disease. People with hepatitis C have a 3 times as much high rate of having a stroke or myocardial infarct. You improve life expectancy. The only proper study which has looked at this is the Pinchoff study in New York State, where they showed in adults, people with hepatitis C had a life expectancy 18 years lower than people without hepatitis C. 60 years compared to 78. People also feel better, they have better well-being, and you cannot underestimate the value of removing the stigma of hepatitis C from someone's life. And we as a society benefit from hepatitis C elimination, and all of these you're aware of. Stopping transmission, improving productivity, difficult thing to gauge. But we also improve use of health resources. I'll see that, I'm already seeing this. We're doing less transplants for decompensated hepatitis C. It makes more livers available for people with other diseases. That's a great use of a very limited resource. And we will reduce health costs. And I think it's the work by Homie and others. And remember, Ian Sheeran did a very good pharmacoeconomic analysis here almost 15 years ago, which will show just how much direct and indirect savings we'll have. So I'll finish there.
Great, thank you. We've run out of time, actually.